Thanks, everyone, and thanks for being here. I really like to thank Dr. Metz for putting this meeting together and inviting us to come and share and learn from each other. Please feel free to stop me anytime if you have any questions. This is my disclosures. Really no disclosures relevant to this topic besides some of the radiographs or CT scan I have on my presentations where from my mentor during residency. So this talk actually started as during my chief year in residency 7 years ago. And obviously we've had some, improvement in managing these patients. And so we put this together a couple of years ago and actually had it published in JBJS. But a couple of the radiographs you see, those are radiographs that I used from the original presentation I put together 7 years ago during residency. So the goal here will be to discuss proximal junctional kyphosis, define proximal junctional kyphosis, and really we'll go over the epidemiology classification, but really highlight the etiology and risk factors, outcomes, and current concepts and prevention strategies. So PJK, we'll call it PJK moving forward, was first described in 1994 by Lowe and Castaigne after correction of a patient with 50-degree kyphosis with Scheuermann's disease using the Cottrell-Debussy construct, so the CD construct with hooks and rods. So proximal junctional kyphosis is defined as the, let me see, there's a pointer in this. Is the proximal junctional Cobb angle greater than 10 degrees or proximal junctional Cobb angle at least 10 degrees greater than preoperative measurement. So if you do a measurement right above the upper, and it's measured from the upper instrumented vertebra, which is the UIV right there, the top screw, from the inferior end plate of your UIV. So let's assume this is T10. So the proximal junctional angle is measured from the inferior end plate of T10 to the superior end plate 2 levels above that. So that'll be T10, T9, T8. So if the preoperative angle was greater than 10 degrees, then it's really not considered proximal junctional kyphosis. But if there's a significant change after that, you would consider PJK. So 10 degrees is currently the most reported and accepted angle for proximal junctional kyphosis. There have been a couple of studies, a study by Britwell, which reported 20 degrees, and they recommended maybe consider 20 degrees as a critical angle to define proximal junctional kyphosis. Another study proposed 15 degrees. Part of the reason you've had this changes in definition, we still maintain 10 degrees, but part of the reason you see some of the suggestions about changing the definition is because majority of these patients are asymptomatic. If you look at the outcome studies. So maybe we should be focusing more on patients who are actually symptomatic. And then you start talking about angles greater than 20 degrees or 15 degrees. So proximal junctional kyphosis is a spectrum. So it's a continuum. So when you say proximal junctional kyphosis, and like I said, majority of patients in most outcome studies, most patients are asymptomatic. So then the question is, why do we care about it? So then we really should. And one thing maybe research should be directed towards is patients with the more severe forms of proximal junctional kyphosis. And then we talk about proximal junctional failure, which is referring now to a symptomatic. As you see, this is a patient we treated during residency. This picture's borrowed from my mentor, Dr. Kavesh. So this patient, osteoporotic patient, had a failure right there, was extended up, and the patient also had a failure, was extended. I think this patient ended up get infused to C2. And so this is proximal junctional failure, Topinoff syndrome, proximal junctional collapse, or acute collapse. So that's one thing I teach even my residents or fellows in clinic when they see patients, because we use patients' medical records right now to communicate with each other. And if you're describing a patient who's coming for a postoperative follow-up with a PJK, if it's proximal junctional failure, either describe it as a symptomatic proximal junctional kyphosis or proximal junctional failure. So when I read your note, I actually understand what you're describing without having to talk to you. So I think that's one way to make it easy for ourselves across the country or across the world. So this is just the incidence of or prevalence of a PJK with using 10 degrees as a critical angle. So in adolescent patients has been reported between 9.2 to 46%. In adult patients, for patients with adult deformity, between 20 to 39%. And with the study suggesting 20 degrees as a critical angle, Britwell reported a prevalence of 27 degrees 27 degrees as they sorry, it is supposed to be 27 degrees of kyphosis. I'm sorry, of our patients with PJK. And for patients with 15-degree critical angle, they reported a prevalence of 5 to 8.2%. Lahner reported for patients with Sherman's kyphosis critical incidence of 30 to 32 degrees. So it most commonly occurs within the first 2 years of surgery, with 43% of idiopathic scoliosis developing PJK within the first year of their surgery. And we know a majority of the angle, the overall angle these patients develop from their PJK occurs within the first 2 to 3 months of their throughout the time they develop their PJK, because as we know from long-term studies, some of these patients go on to develop PJK in a year or 2 years after. So mode and location of failure. So in the upper thoracic spine, the most common cause of PJK is typically a soft tissue failure. And we had to talk during the opening of the meeting with Dr. Dan Rue, and he talked to us about disrupting the posterior ligamentous complex at C2 and C7 for cervical spine. For patients with adult deformity, most of the time the failure in the upper thoracic spine is due to disruption of the soft tissue. So we try to do a good job of maintaining that soft tissue over the upper instrumented levels when we do surgery. So either from soft tissue failure that can lead to subluxation because you've disrupted either the posterior ligamentous complex or disrupted the facet capsule, so you can end up with subluxation. Within the lower thoracic spine or the thoracolumbar junction, the most common cause of PJK is actually fracture or hardware failure or hardware cutout. So some form of fracture or bone hardware compromise leads to PJK. Grading system was described using grade A, B, and C depending on the degree of the angle, and then the type describing the type of failure, whether it's ligamentous or bony failure or implant failure. So taking a step forward to try to understand the risk factors for proximal junctional kyphosis, we'll look at the outcome studies. And based on univariate analysis, and as we know, it's not necessarily the best statistical method, but based on univariate, if you look around and do a review of all the majority of the articles published, so these are the various factors that have been reported as risk factors for PJK: age, BMI, bone mineral density, gender, thoracolplasty, so all that listed. If you look at multivariate analysis, lower risk are great. So these are patients who are still growing, upper instrumented vertebrae at T1 to 3, combined anterior posterior surgery, overcorrection of SSVL. These are all risks, taking into account all the different confounding variables. These are the factors that have been shown to cause PJK. So now, using all the different reported risk factors, we can group those risk factors into patient-specific risk factors, surgical risk factors, radiographic risk factors, and but we still truly don't understand how significant these various risk factors contribute to PJK. So we know it's a multifactorial problem. And focusing more on looking at different risk factors, so patient-specific risk factors, gender. So this is something, male gender has been shown. Male patients have had a higher risk for PJK in various studies. Older age, larger BMI patients. And as I showed earlier, this is mostly based on univariate analysis, not necessarily taking into account all the different confounding variables that would affect the outcome. A few days ago, we talked about getting MRI or some studies using MRI to look at muscle mass. So yes, you can look at muscle mass on MRIs after surgery, but how does that affect the patient clinically? And that's something we still, we truly don't understand why some of these things predispose patients to PJK. And curve flexibility is something that's been reported recently as far as looking at thoracic curve with patients. Dr. Lanky mentioned earlier, we get most of our radiographs with patients standing up with their hand across their shoulders. So as surgeons, we spend most of our time standing up. But if you look at majority of the population, people are sitting down. So there've even been some questions about whether or not we should be using sitting down images to evaluate patients' true alignment, or whether you should be using supine or prone flex X images to determine the patient's true flexibility of the thoracic spine before surgery. So surgical risk factors, so or we can call them iatrogenic risk factors. So a type of instrumentation has been reported as that can predispose patients to PJK. Doing anterior and posterior instrumentation can predispose patients to PJK because the theory is that with anterior and posterior instrumentation, most of the time you may overcorrect the patient because we're using maybe large antibodies in the front from ALIF procedures or lateral procedures. And you're creating a very rigid segment. Proximal instrumentation level, so trying to figure out where you want to stop your construct so that UIV, the goal, always try to avoid stopping within the kyphotic angle or kyphotic segment. Pelvic fixation. So we know majority of these patients, especially in adult spine, get fusion down to the pelvis. So once you create that rigid spine below, there's really nowhere else the spine can move. So the patient is fixed from T10 to pelvis. There's really not much flexibility within the pelvis. So patients are susceptible to develop proximal junctional kyphosis instead of distal junctional kyphosis. And also we talked about the ligamentous complex, so compromising the integrity of the ligamentous complex. So moving on to another grouped risk factors, so radiographic risk factors. This image is an image described by, so the cone of economy was described by Dr. Jean de Beausset. So the cone of economy is that angle that's projecting from the feet and upwards. So it's a range of motion your body can tolerate without external support and with minimal pain. And if you can restore someone's alignment within that cone of economy, so they have very little pain and they're able to, still maintain some coronal and sagittal imbalance, but within that cone of economy with minimal pain, that's what we should be aiming for, and not necessarily to get every patient perfectly standing up perfectly. So patients who fall outside this cone of economy are patients who would describe sometimes as having deformity or symptomatic deformity. Our current literature on sagittal alignment, which is what we use for radiographic parameters to determine the outcome of our surgeries, is based on Schwab criteria. It's mostly based on Schwab criteria and sagittal with the sagittal modifiers. So we talked about between cervical and lumbar, so C7 plumb line, thoracic kyphosis, lumbar lordosis, pelvic incidence, sagittal vertical axis. Understanding that one of the most consistent variable that doesn't change much is that pelvic incidence. So moving forward to prevention techniques. And so when we talk about prevention, then now we have patients grouped into patient-specific risk factors, instrumentation risk factors, radiographic risk factors. So if you look at most of the techniques that have been developed or described as techniques to prevent or reduce the risk for PJK is based on really addressing either the patient-specific risk factors or radiographic risk factors or the patient. So fixation techniques, we talked about instrumentation at the UIV. So pedicle screw fixation provides us with rigid fixation. We've talked about using larger screw diameters and using screw density. So it gives us a good fixation which can lead to high fusion rate. But the concern with that sometimes is that you create a very rigid spine and there's nowhere else for that motion to occur. So just like patients just developing adjacent segment disease. In these patients, most of the forces or the flexibility of the spine ends up just above your UIV, and that's why the patients fail at the top. So even though it can afford us a better fixation and fusion, we still end up with with significant motion at the top of the construct. And if you look at pedicle screw instrumentation at the top of the construct, this can typically lead to disruption of the posterior ligamentous complex. So as we talked about during surgery, there's certain critical aspects of the surgery. We work with fellows and work with residents. Sometimes I think as the attendant, you have to, I personally, when I do dissection at the top of the construct, is a technique I learned from Dr. Erica during fellowship. Very minimal disruption of the soft tissue at the top. I expose just enough to know we talk about preoperative planning. I've reviewed the CAT scan, and you review your x-rays, and you've determined where your upper instrumented vertebrae will be. And I expose just enough to see where I need to put in my screw. I don't need to see the entire facet joint. I don't need to go all the way out on the transverse process at the top of the construct. and I keep the screw in a more anatomic position, and that reduces, classic screw placement right below the end plate, or which can sometimes lead to end plate erosion and failure. So that's one of the ways you can use. So I still use pedicle screws despite some of what we'll go over, but part of it is just knowing what works best in your hands to minimize the risk for the PJK. So as I discussed earlier, just minimize the disruption of a posterior tension band, meticulous dissection, you maintain the interspinous ligament. I use more of like a chevron exposure at the top of the, within the top two levels at the UIV and UIV -1. I actually take the dissection away from the interspinous ligaments and just out to just see just the top part of my TP, the top and medial section of it, and I place my screw. I do it freehand, but if that's something you decide to do, if you feel more comfortable doing it on the fluoroscopy, I think that's a good strategy, and I think that's something that navigation too might help with reducing the amount of disruption in order, because some people need to see most of the facet joints or the TP in order to feel comfortable placing the screw. Vertebroplasty is another technique that's been described. We did a good number of these studies during residency at Hopkins with Dr. Kabesh. And the early reports, 1 year, 2 year follow-up studies reported very promising, give us very promising results with a significant reduction in the risk for PJK. So a lot of people adopted this technique. So this is what we talked about, new technology or emerging technology. Sometimes it's not necessarily the best thing to jump on them just because it's a new technique. So you really have to look at long-term data to see how these patients do. And if you look at the 2-year follow-up study from Dr. Kabesh and also from Dr. Jolach in Miami showed very promising results with significant reduction in risk for PJK. But if you look at the 5-year, it was actually a 5 to 7 year study. A lot of those patients who initially at 2 years had no PJK actually developed PJK or developed symptomatic PJK that required revision surgery. So this is an example of one of those patients from the long-term follow-up study. So that's a patient at 1 year follow-up. The patient had a vertebroplasty. So typically, I would recommend doing a vertebroplasty at the upper instrumented vertebrae, and sometimes 1 or 2 levels above that. And the goal here is, or the theory is that you distribute the forces or the rigidity of the spine within those segments. But clearly, this is a case you see the patient had a vertebroplasty at 1 year, had some PJK, but asymptomatic. At 3 years, started developing some more progressive PJK, and you see at 5 years, develop more of a proximal junction of failure now, and the patient had a PSO and extension to the upper thoracic spine with hooks at the top. Other fixation techniques to use to prevent or reduce the risk for PJK is using shear loading. So we started out discussing, first report of PJK was for patients who are using the CD construct for Sherman's kyphosis. And we've almost made a U-turn to go back now to look at use of hooks instead of the rigid rods at the top of the construct. So the theory is that the hooks can afford a more softer landing zone and creates less rigidity at the top of the construct. And so because of the improved range of motion flexibility within the upper instrumented vertebrae, it reduces the risk for PJK. And so the multiple studies have been published regarding use of hooks. And some studies have actually looked at use of hooks, going back to use of hooks and rods instead without using any screws. Or use a hybrid construct where you have your screws at the bottom and use hooks at the top. Or also looking at all pedicle screw technique. And in majority of the studies, there's a significant reduction in risk for PJK with use of hooks at the top of the construct. Is one of the studies that was done with some of our patients during residency, which showed a significant improvement. No PJK for patients who had strictly hooks at the top of the construct. So we have all these different techniques that have been described: vertebroplasty, use of screws, use of hooks. Tension band is something that's becoming more popular right now. And but overall, the data actually shows that use of hooks is the best technique to reduce the risk of PJK. Use of tethers. So over the past few years, there have been some reports about use of tethers to reduce the risk of PJK. And the same concept, you reduce the tension within the top of the construct or the upper instrumented vertebrae. And I'll go fast forward here a little bit. So this is different constructs that have been described. So here they use, you see the first image is a UIV tether at UIV plus 1. The second image tether at the UIV plus 2 and then UIV plus 3. I've never placed a tether in a patient, and I would imagine in placing these tethers, and one concern that you get from even for those who've used it and reported on it is sometimes you end up disrupting more tissue in order to place the tethers. And we know just biomechanically and from a lot of biomechanical studies, once you disrupt the natural tissue, it's hard to replicate. So you can put synthetic materials to try to reinforce that area, but why disrupt that in the first place? So maybe we'll get the opinion of if anyone uses tethers within the upper instrumented vertebrae to see their reports or their experience with using that. But I personally would imagine that would lead to more disruption. But the goal is that by use of using tethers, you reduce the proximal segment range of motion. So just looking at this pointer, I'm blocking it myself. So if you look at the range of motion for patients, so you have just UIV minus 1, range of motion was 91 degrees, 91%. And tethers within the transverse process with transverse process hooks, or just transverse process hooks minus 1, you see the range of motion was 92%. And if you look at now using different tether configurations, whether it's UIV plus 1, UIV plus 2, or UIV plus 3, and just looking strictly at the range of motion within the UIV, you see there's a significant decrease in the range of motion within the UIV. I found it interesting with this study, they looked at, you see the range of motion increases at the UIV plus 1. If you start at UIV plus 1, if you stop the tether at plus 1. So it's almost similar to patients without the use of tethers. And so basically the gist of this study was that if you use the more tethers you add, the better your range of motion at the top. But if you notice, they did not provide any data on tethers at UIV plus 3. So I don't know if it's because it had similar increased range of motion similar to patients with regular instrumentation. So this is different studies that have reported on use of tethers showing improve. One of them is just a 3-month follow-up. It's a 1-year follow-up showing a reduction in the risk for PJK. So we talked about global alignment and maintaining patients within the cone of economy. Again, it's a range of motion your body can tolerate without any supportive or assistive device with minimal pain. And as long as patients maintain this range of economy, the risk for developing symptoms is low. So maybe a treatment techniques or surgical techniques should aim at maintaining patients within that range of economy instead of sometimes overcorrecting these patients. So again, most of the reports we have on sagittal alignment is based on Schwab criteria and with sagittal modifiers. The goal, as we mentioned, is really to restore patients within a global sagittal alignment. Now, what exactly is a global sagittal alignment? We have general principles to guide us, but is it specific to each patient, or is every patient the same? Should we be aiming to give every single patient of thoracic kyphosis of 40 or lumbar lordosis PI minus similar or plus minus the pelvic incidence? So maybe we should consider not every patient has to be within what we consider to be the global sagittal alignment. So overcorrection, we know, is something that can predispose these patients to proximal junctional kyphosis. So we know incomplete restoration of the lumbar lordosis, overcorrection of the C7 plumb line, those are all risk factors for PJK. So Dr. Lanke and his group reported on age-based normative sagittal alignment in asymptomatic adult patients. And based on from that study, they reported increase in age correlated with increased C7 SVA, T1 PA, global sagittal alignment, knee flexion angle, PI minus LL due to decrease in lumbar lordosis with age. So that's something, so we know as patients get older, these factors change, but majority of the time when we're planning, when we're doing our preoperative planning for these patients, we don't necessarily take into account the fact that, that 75-year-old lady doesn't necessarily need to be standing upright. Maybe we'll live them with a little bit of a positive sagittal angle to reduce the risk for PJK. So increase in rate for mechanical failure, including PJK and revision surgery, despite observing and following sagittal alignment based on Schwab criteria. Normative, normal and pathologic alignment of the spine still remains unknown. So maybe focusing more on patient-specific criteria to determine the overall or the alignment parameters may help us reduce the risk for PJK. And we know, looking at all the different sagittal parameters for balance, we know PIs are only relatively constant parameters. And so using the gap score, which Sig mentioned earlier, some studies have looked at that to really use patients, make this more patient-specific. So you do, various relative risks for PJK, looking at different parameters. What is your lumbar lordosis? What is this specific to that patient, and not necessarily using global parameters? We know PI, as I mentioned earlier, is a continuum reported between 27 and 30 degrees, and we typically would use that to determine the patient's lumbar lordosis. So we know standardized sagittal parameters might not always be pathologic for some of these patients. And so distribution of lordosis is also not taken into account if you look at Schwab criteria. As Sig mentioned earlier, what do you use when you try to determine where the lordosis of the spine should be? And we know it typically should be somewhere between L4-5 and L5-S1. So gap score, the goal for this was to develop and validate a score system for alignment, which was more patient-specific, and maybe better assist us with planning for a surgery, which is tailored to each individual, and help us reduce our risk for proximal junctional kyphosis. It was a multi-center study. They did this study and then also did a multi-center retrospective study to look at the risk for mechanical failure, and they had described various classifications for patients with either severe, moderate, or mild proportional parameters to see the risk for mechanical complication, including PJK, which was the most commonly reported complication. So for using the gap score, if the correction was, so they reported 6% of patients with proportion spinal pelvic state according to the gap score, only 6% of those patients develop PJK or mechanical failure, including PJK. But that went up to 47, the rate was up to 47% for patients with moderately disproportionate spinal pelvic state, and up to 95% for patients with severely disproportionate state. So it was, you read the study, you feel it was a study published in JVJS, it was a good study, but obviously, as I mentioned, the goal is really to look at long-term outcomes. And there have been some studies that have reported on this with 2-year follow-up outcomes showing they were able to replicate what was demonstrated, what this study reported. And there have been some studies that have reported that they were unable to, but part of it, I think part of the problem is the patients that we treat. So some of these are revision cases, and the heterogeneity with some of these patients is hard to really group them all and use the same parameters for all of them because of the different patient population and different deformities that we treat. Looking at quality of life measures, there was a significant improvement in quality of life, looking at all the different quality of life parameters except for the SF-36, if the correction was done based on more proportion gap score. So as I mentioned, most of the studies we currently have to help us prevent or reduce the risk for proximal junctional kyphosis is small studies, case series, limited short-term follow-ups, and we currently really do not have any consensus guideline for PJK prevention. I think, again, one of the most consistent studies that have shown, techniques that have been shown to reduce the risk for PJK is use of hooks. But again, how many of us use hooks and are comfortable placing those hooks without further disrupting soft tissue at the top? So future studies, we need to validate and define thresholds for patient-specific sagittal parameters to help reduce the risk for PJK. Bone marrow density, as Cal mentioned, is something that I think the more we learn about PJK and improve our treatment for patients with deformity, I think we have more surgeons now taking this into account. I recently saw a patient 2 weeks ago who came for a second opinion who already had surgery scheduled. And you look at an x-ray, it looked like she barely had any bone, but surgery was already scheduled and she never had a DEXA. Then she went home, I gave her my opinion. She went home and called my office and said she wanted to book a surgery. I was like, no, we have to start from scratch. So even though someone else was going to operate on you, it doesn't mean I'm just going to pick it up and say, this is what I'm going to do. We have to get the DEXA scan and start the workup, because as much as she thought she was ready for surgery, I personally didn't think she was ready for it. So we need to I think more validation of the GAP score. There have been a few studies looking at that, and then look at the clinical significance. I think maybe focusing more on clinically significant PJK or PJF. As a lot of studies initially with PJK were done mostly it was for all comers, and then we found out most patients were actually asymptomatic compared to patients without PJK. So my personal approach, as I mentioned earlier, I get a DEXA scan. We have a metabolic bone clinic within our institution, so patients are sent to the metabolic bone clinic. For patients with osteopenia, we start them on some calcium and vitamin D. So again, appropriate selection of the UIV. So I think a lot of this comes with preoperative planning before you actually go into surgery. And then during surgery, we do a meticulous dissection at the upper instrumented vertebrae once you've determined what that will be. Maintain the interspinous ligament exposure limited just to the site where I know my screw will be going in. And I still use screws at a UIV, and in my hands, I've had a very low rate of PJK, and partly it's because I don't use hooks, because maybe I should put in the effort to learn how to use them. But part of with hooks too, we can get the opinion for some of the senior surgeons in the room with the experience with using hooks. But I would imagine that it will probably lead to some disruption of the soft tissue you're trying to maintain. I use joint brace postoperatively for some of these patients, so even though we know we have studies that have shown no significant changes with use of external bracing after deformity surgery, but I think most of us still use it. Patients, we use it just when they're out of bed. I don't have the patients wear the brace when they're in bed, and then we continue with the calcium and vitamin D for patients with poor bone mineral density. Thank you.